we'll start with our own Professor Josu de la Fuente, well-renowned in terms of sickle cell transplants, and he's going to give us a good perspective on it. Thanks, Josu.
Thank you, Kofi. And I hope I talk something that is useful. But first of all, you may imagine it was my dream since I was an SHO to speak in this room. So thank you, Kofi, and everybody who has enabled it. Never, I would have thought I would have been talking in the library of the Royal College of Physicians, where I sat my first Part 1 exam. So I'm still a bit nervous. Good. So do feel free to interrupt me and stop me if anything is not clear. Those are my disclosures. I don't think you can see them all, but they are all related to all the existed gene therapy companies, not one in particular. So sorry, Tom, but you're not the only one. Now, this is the actual activity of EBMT in relation to hemoglobinopathies, just to give you a flavor of where we are going in transplantation. There are two big registries worldwide. One is based in Milwaukee in the US called CIBMTR that collects mainly American data, although there are some certains worldwide like us that report to both places. And the other one is EBMT, which is headquarters in Barcelona, but distributed across a number of different European countries, to which mainly European and Middle Eastern and Asian countries report. And so that gives you a better flavor of hemoglobinopathies because it's very rare to have thalassemia patients in the American registries. But for sickle cell disease, of course, is equally prevalent. So what you see here is, so you have the patients distributed between thalassemia and sickle cell disease, between children and adults. And I want you to focus on the red, which is the adults with sickle cell disease, and on green, which is the children with sickle cell disease. And so if you go back onto 2010, you can see that most transplants were for thalassemia, and most transplants were for children. We have a drop during the pandemic, because at that point we were only transplanting patients with leukemia, and then the recovery phase post-pandemic. And what has become very clear is that the combination of children and adults with sickle cell disease is far greater than the number of patients with thalassemia, the blues. And so sickle cell disease has now become the first and most important condition to be transplanted. And what is even more striking is the fact that the number of transplants for adults with sickle cell disease has rocketed and is almost in numbers as important as the number of patients in the pediatric age. So in fact, a quarter of all the transplants for hemoglobinopathies that occurred at the moment in Europe and Asia are thanks to sickle cell disease. And why is that? Well, I hope I'm going to be able to show you in the rest of my talk why we have reached the point that transplantation has very good outcomes irrespective of age, and where with well-selected patients, we can achieve a cure for the majority of the patients. Of course, I accept that transplants are procedures which are not only lengthy and complex and have a great impact in people's lives and their families, but they do require the use of chemotherapy, and they do have a risk of death from which we cannot get away. But that risk is now below 5% or up to 5%, which in the context of a very serious condition it makes it an acceptable form of treatment. So we have been looking very hard at real-world data of transplantation in sickle cell disease because now it has become a very widely available form of treatment. There are also alternative approaches like gene therapy, so it makes you think, which patients ought to have gene therapy, which patients ought to have transplantation, and so we can only decide that if we know exactly what happens with conventional transplantation. And the best way to do this is not just to focus on individual centers who might have a particular expertise, but looking at worldwide registries, because that way you move away from individual biases and individual results onto actually what the therapy can provide you. And so that's the reason we have been looking at the EBMT registry for a period of 10 years to see exactly what are the outcomes, and focusing not just in the ability of being cured from sickle cell disease, but whether you are cured from sickle cell disease without having complications of your transplant. And the main complication that we all worry about is graft versus host disease. So this is the reaction of the new bone marrow attacking the body of the patient, which can be as severe or worse than sickle cell disease itself. So in the EBMT database, we have 1,331 children and 484 adults. They are spread across 36 countries, although I accept that there are 10 centers that perform the majority of the transplants. It still remains relatively concentrated in centers of expertise. And if we move away from the centers in Saudi Arabia, the largest, the non-Saudi largest center worldwide, I'm very proud to say that is our center. And it contributes around 1 in every 8 patients that you're going to see in these slides. So when we talk about children, we talk about the age up to the age of 18. You can see that the median age of the children is 9.6 years. The adults, the median age is 26 years. And we are talking about a 10-year period. But you see that the median year at which the transplants have occurred is 2017 for the children, 2019 for the adults. That gives you an indication that most of the transplants have happened in the last few years, as people feel confident that this is a worthwhile treatment to offer. 4 out of 5 transplants come from a match-related donor, but we already have 20% of the transplants using donors who are not related to the patient and fully matched, so either unrelated or mainly what we call hypothetical transplants. So this means donors who are only 50% matched to the patient. And one of the largest problems that we have in treating patients with hemoglobinopathies is that the people who are willing to be donors worldwide, there are lots of variety of reasons for it, are on the main people of a Caucasian background. So it's very difficult to identify unrelated donors for hemoglobinopathies, but actually it doesn't matter, because we have reached the point that doing 50% matched transplants gives you as good results as an unrelated transplant. In fact, we are becoming very close to being as good as a related transplant. So the majority of the transplants we do continues to be with bone marrow, and that is still poses a challenge sometimes, because donors prefer to give peripheral blood. This is when you collect the stem cells from the bloodstream with a special apheresis machine, rather than having to do a general anesthesia and a big operation in theater. Understandably, is more comfortable for the donor, but having a bone marrow reduces your chances of graft versus disease. Now, that is not true for the adult population, because of the techniques which I'm going to show you that have been developed to be able to do transplants with peripheral blood stem cells. And increasingly, we are moving on to preparations of chemotherapy, conditioning regimens that don't have as high intensity as they used to have in the past. So in children, we are moving away from the use of busulfan onto triosulfan-based regimens, and in adults, we are moving away from chemotherapy altogether, just using radiotherapy and antibodies. And one thing that is very different from transplants for leukemia or for other disorders is that we always use antibodies to remove the risk of graft versus disease. And so whether you are a child or you're an adult, the ability to recover your blood production post-transplantation is exceedingly high. Children, because they have a very active and expanded bone marrow, trying to cope with the anemia of sickle cell disease, can be particularly difficult to ensure that the new bone marrow engrafts, that it gets settled long term. They have a higher risk of rejection. Adults, you have the risk that if the transplant is not well tolerated, they don't even survive, or they didn't used to survive, until the possibility of engrafting the bone marrow. But you can see that both in children and in adults, the vast majority of people, there is only around 2%, 2.1% of the children and adults who, by day 42 after transplant, have not engrafted and who have rejected. And these are the outcomes. And so with a fairly long follow-up, you can see that we are not talking about people who had the transplant 3 months at the time of analysis. We have 3 years follow-up for children as a median, 2.6 years for adults, that we have a situation where over 95% of the children survive the transplant, over 93% of the adults. And you can see that this is across multiple centers. So when you handpick, as you will see, the experienced centers, these results become even slightly better. But that over 90% of the people get cured from the original disease. And the number of people who require second transplant because they have rejected is less than 5%. And around 85% of the patients, whether you are a child or an adult, so truly doesn't make a difference, will have a transplant that is successful and don't have graft versus host disease. Now, for those who are not in the transplant world, you might think, 86%, 85% is rubbish. Actually, this is amazing results. So there will be, of course, another 10% of the people who are alive and cured of the disease, but who have had to be treated for graft versus disease. And with time and with treatment, the graft versus disease will go away. That doesn't mean that only this percentage of people are cured in an acceptable manner, and eventually the majority of the people will. But that even 85% of the people don't require any significant treatment for graft versus disease is fantastic results. And if you were to do equivalent analysis for people with leukemia, that will probably drop to somewhere in the 60s. And the reason for this is, as I'm going to show you in the next slides, is because we put a lot of effort in reducing graft versus disease in the way that we do the transplants. Those are the rates. Acute graft versus disease is what happens in the first 3 months, and chronic is what happens in the thereafter. And we particularly focus on what we call extensive graft versus disease, because that's the kind of graft versus disease that is going to have a longer impact in your life, and it's going to delay your recovery and return to school or to work. And you can see that that extensive GVHD only happens to around 5% of the people. I'm not trying to dismiss it. I think even 5% is 1 in 20 is still significant, and we're still making efforts in reducing that. But in comparison to what we normally expect following a transplant, these are results which are generally acceptable. So in fact, when we look at all the different things that can impact on your outcomes, was the age of the patient at the time of a transplant has an effect on your ability to survive transplantation. And you can see that you have a 2 times greater chance of not being alive if your transplant is after the age of 12 rather than below the age of 12. And that is 2.47 times greater chance of death when you do it above 18 years of age. Whilst there is an impact in your ability to be alive, and that is still telling us that if you want to be cured for transplantation, you should get on with it and don't delay it, because the younger is, the better. And so I fully accept that some people's the risks are too great, the intensity is too much, it may not be what they are seeking, but if you are seeking it, you ought to do it as early as possible without wasting time. Because the age has not effect on the graft-versus-host disease, either in the acute area that can be dangerous to life or in the chronic area that often affects your quality of life, because the AIDS doesn't have an impact on this, when you actually put all together and you are looking at your ability to survive without GVHD and without sickle cell disease, the outcomes are the same whether you are a child or an adult. And then the other important thing is that transplantation, like any other area of medicine, is improving. And so whether your transplant was below 2015 or after 2015 has had a very significant effect. And that is because we now manage graft-versus-host disease and chronic graft-versus-host disease, both acute and chronic, much, much better. We have an ability, because we have better medicines and better approaches, to deal with it. So, I'm now going to start showing you what we actually can obtain with the different forms of transplantation. So this is focusing on the work that we do at St. Mary's, so children up to the age of 19. And these are our last 80 transplants up to August 2024. And you can see that in those 80 patients, we have only had one death, that nobody has had failure to engraft the cells, although we have had one patient who had a year later a rejection. Late rejections, unfortunately, can happen occasionally. That we have rates of graft-versus disease which, as you can see, are very acceptable. We have had only one case of grade 3, grade 4, and nobody has had grade 4. And that was 10% of the people have had moderate to severe chronic GVHD. By the age of 18 months, there has only been one patient that has required treatment, because all the others were able to be effectively treated. And that means that a child coming to transplantation to us can expect to have an ability to survive the transplant of 98.6% with a 97% chance of being cured of the disease. And so this in part reflects that this is a pediatric population, and so, early transplantation before you have organ damage will give you good results. Now, the world of the adults has been transformed by the use of non-chemotherapy transplant approaches. And so this was initiated by our colleagues at the NIH in Bethesda, and has then been, I hope, improved further by the work that I've been doing with our colleagues in Amsterdam. And we had this published last year, which involves using just low-dose radiotherapy, that's what we mean by total body irradiation, and antibodies with no chemotherapy at all, but with very strong suppression of the blood production pre-transplantation with the use of azathioprine and hydroxyurea. And then they need to be with immunosuppression with a medicine called sirolimus for approximately a year. And doing this technique, we are able to ensure that the new bone marrow, which is in red, comes from the donor. You can see that it's almost 100% from the donor. And although the immune system cells, the T cells originally are mixed from the donor and the patient, so they're only 40% of the cells are from the donor. If you manage the immunosuppression correctly, you are able to increase them over the first 2 to 3 years to the point that the patients are able to stop all medication by 18 months. And so the early results from the NIH that some of you may be aware of, where 50% of the patients are able to stop all medication, and that at least half of the patients retain donor T cells, only around 50% of the total, is something that I think we have been able to alter. And now the majority of the patients, in fact all the patients, stop immunosuppression. So by 18 months, all of them have stopped immunosuppression. And we are getting very high levels of both blood and immune system production. And I hope that gives reassurance for adult patients to come forward for transplantation if they have a brother or sister who is fully matched to them. And this type of transplantation, the donor gets the cells collected with the apheresis machine, so they don't even have to have an operation. And we are extremely happy to do them at the Hammersmith. And if you have a patient or you yourself or somebody know it, refer them. You can refer them to Stephen, you can refer them to me. I have just done a patient in the last 3 months who is doing very well. You can feel confident that we can do this. Now, what really has expanded the number of transplants is what I was talking about before, the ability to do 50% matched transplants, what we call haematological transplants. And as this is an Imperial meeting, I have to show you this. So the technique was applied to sickle cell disease by our colleagues from Johns Hopkins in Baltimore, whom started to do this around 2010, 2012, but based on work that in the 1960s, a pathologist called Dr. Barenbaum had done, in which he realized, working in rats, that you could do a skin transplant, which were only 50% matched, and if you gave 2 doses of a chemotherapy drug called cyclophosphamide, after you had done the transplant, which is a bit weird, you were able to tolerate the mismatched graft and make the mice survive. And the reason why we feel very proud is because this guy was a pathologist at St. Mary's, and he finished his career as a pathologist in the Department of Immunology at the Hammersmith. And this work that he did that lay dormant for decades until it was revived by the Johns Hopkins group has actually transformed transplantation, and is the technique that worldwide is now mostly used for all mismatched transplants. Unfortunately, Dr. Barenbaum died around 20 years ago, 25 years ago, and didn't have any relatives. So we haven't been able to go and tell somebody, you transform medicine. Anyway, now the way this works is because the ability of stem cells and the ability of the immune system cells to clear the cyclophosphamide chemotherapy is different. Stem cells can clear it without being damaged, whereas immune system cells can't. And so what we do is, we do the transplant. You can see the cells within the bone, and they survive being given 2 doses of chemotherapy. Whereas the immune system cells start to interact with the new body, they start to react, and the chemotherapy destroys them. And so that allows us to do transplants which are mismatched. The protocol looks a bit like that. So they get reduced intensity chemotherapy, so they only get fludarabine and low doses of cyclophosphamide and low doses of radiotherapy pre-transplantation. And this allows us to do transplants in adults and even in adults who have renal disease or who have pulmonary hypertension. We do then the transplants, and then we give 2 doses of chemotherapy post-transplantation, which are the key doses that allow us to take away the reacting cells. And the bits in red are the bits that we have added at Imperial, working with our colleagues in Vanderbilt in refining this protocol that has become the main way of doing transplants when people don't have a matched donor. And so this is the data from the work that we have done with our international colleagues. So we are looking at 70 people, and all of these are 50% matched transplants, and you can see that whether you are an adult or you're a pediatric patient, you have a survival of the transplant process which is around 95%. So that's not different from having a transplant, not significantly different from having a transplant from a brother or a sister. In the adults, you can see that the rates of graft-versus disease are particularly low. There is an increased risk of having graft-versus disease with this technique in the children of 18.8%. So that draws our attention because normally the younger you are, the less graft-versus disease that you tend to have. But the problem is that if you're going to do a haematological transplant, the chances are that if you are a child, your bone marrow is coming from your mom or your dad, from an adult. Whereas if you are an adult, your bone marrow is coming from your brother or your sister, who is probably in the 20s like you. So the children are getting bone marrows from people in the 40s, whereas the adults are getting bone marrows from people in the 20s. So that's probably the reason why we get more graft-versus disease with this technique in children, but we have a way of dealing with it now, which we didn't when we first were doing this. Now you might say, well, you guys, that's good, but the people who contributed to this work, it was you at Imperial, and it was our colleague Adetola in Vanderbilt, and your colleagues in Riyadh, in Saudi Arabia, and you're all guys who've been doing transplantation all the time, and you know how to do this very well. How can I trust this? And if I don't live close to your center, should I have this type of transplant? So what we then do is we did a trial called the BMT CTN 1507 trial throughout all the hospitals, all the hospitals who wanted to participate, but it was the majority of the transplant centers in the US. And so over 40 different transplant centers participated, most of which had never done a transplant for sickle cell disease, so you can't claim that there was a particular expertise, and everybody contributed, 1, 2 patients, so there was a good spread throughout all the centers. And despite of doing that, you can see that the 2-year survival of hepatorenteral transplantation with this technique is 95%. So you have assurance that we now have 2 good studies of large number of patients whom show similarly the safety of having a haematological transplant. And it's a very interesting thing that we then try to compare this with a cohort of patients with sickle cell disease in the US. And so we calculated what are the chances of you dying with a transplant, what are the chances of you dying with sickle cell disease. And so the risk of dying of sickle cell disease between the age of 18 and 36 in the Tennessee area is 2.36 deaths per 100 person years. Once you get over the age of 36, it goes up to 4.72. The risk of dying of the transplant is 2.31. So you're actually not increasing your risk of death by having a transplant. There is a risk of death, I don't deny that, and it is always difficult for patients to accept this, but it is a risk which is not different from the risk that you face by having the disease itself. And so the next question is, what can we do about stopping that increased risk of graft-versus disease that we have seen in the children? And a new drug appeared around that time. Well, it's not truly new because this drug, abatacept, has been used for a number of years to treat rheumatoid arthritis and other kind of immunological disorders, but it was new to the transplant world. And it is now licensed for the management of graft-versus disease in the US. It's not quite licensed in Europe, although they are in the process of doing it, but because it has the license in the US, we can use it. And so we have done now 30 pediatric transplants. In fact, we have done more, but I didn't want to come right till now because I wanted to give some time to see the effects of the treatment. We have added abatacept to our transplants, and what I want you to look is at here. So we have had no grade 3, grade 4 graft-versus disease in the acute part. We have only had 1 case of chronic graft-versus disease, and we have had no deaths and a 100% cure rate. And so we now feel confident that we can offer hematopoietic transplantation to the children also, knowing that they have no increased risk of graft-versus disease. So I hope I have been able to show you that the real-world data demonstrates that transplantation offers excellent outcomes irrespective of age, that the reduction in toxicity by reducing the regimens allows us to transplant across the HLA barrier, so it doesn't matter anymore whether you have a fully matched donor or not, and that the addition of abatacept is abrogating that increased risk that we had seen previously in the pediatric population. And so if you're somebody who has a degree of severity of sickle cell disease that will warrant a curative treatment, that you can have confidence either as a clinician, as a doctor, as a nurse, or as a patient, that going for transplantation is a reasonable thing to do. So happy to take any questions.
Thank you so much, Josu. Excellent data. Yeah, a couple of questions.
It's just a quick one, thanks. Is everyone offered a transplant now when they have sickle? Is that mainstay or?
So that depends very much on the frontline people looking after sickle cell disease. It is one of the standards of the care of sickle cell disease that at the annual review, you should assess with the family whether it is the appropriate and the right thing to do. You ought to also make an effort in doing HLA typing of the family members to know whether that is a feasibility. I mean, the reality is that haploidentical transplantation is now becoming very close in its outcomes to sibling transplantation, but we still, quite rarely, I think we leave it for the more severe cohort. But you should be considering it on an annual basis, both from understanding the wishes of the family or the patient, understanding what is the feasibility, but also giving an opportunity for the patient to have this. I mean, often, as a, in my role as a transplant person, which is only 50% of my job, I often get accused of, less so, but historically we have been accused of doing things to children and this and the other. And I don't go to people's school gates collecting children. They only come to my clinic if they have been referred by pediatricians or haematologists who think that the child requires a transplant.
Good. So.
Thanks, Josu. Is there any place still for considering unrelated donor transplants, matched unrelated donor transplants, or cord transplants? Yeah. And how does gene therapy fit in compared to haploidentical transplantation?
Yeah. So there is no evidence that any of the different forms of non-sibling transplantation are better than the others. So it doesn't mean that unrelated transplantation is not good, but it's not better than doing a haploidentical transplant. And so the benefit of doing a haploidentical transplant is that the donor is going to be a family member, so you have control as to when that donation can happen, and if you're required to top up the stem cells in the post-transplant period, they are readily available there, whereas sometimes unrelated donors might not wish to donate a second time if that were to be necessary. There is also a very important economic cost, is that purchasing an unrelated bone marrow is somewhere around 30,000 to 40,000 pounds. Whereas the cost of a donation from a haploidentical donor is probably £2,000. And so, you are struggling sometimes in the provision of apheresis or a nurse or a colleague. I only have to avoid 1 or 2 unrelated transplants, and I have funding for all of that. And so one has to be responsible. The only situation in which we are careful, and this is particularly with the children, is that once you get into mismatched transplants, it really doesn't matter whether you are 80 or 70 or 60 or 50 matched. And we often have families that the parents are into the 50s, or certainly the late 80s, or the parent might have sickle cell disease, and the other parent is no longer in the scene, or they have another medical problem that no longer makes them suitable donors. Okay, you don't want to put the bone marrow of a 50-year-old in the body of a 6-year-old. I mean, it will be okay for the next first 10, 15 years, but it will be the bone marrow of a
Aging.
80-year-old when the guy is only, 40. And so increasingly, we are seeking unrelated mismatch donors who are in the 20s and using them as if they were haploidentical donors in the pediatric population. I think that is less likely to be a problem in the adult population because you are more likely to have a cousin or a sibling who are of a similar age. But it could also happen that you are the only member of the family who is willing to donate and is available. What to do with gene therapy? Well, I don't want to steal Tom's thunder. And of course, Tom is restricted in a way I am not restricted. So gene therapy has a benefit, is that you're using your own stem cells that have been corrected, so you don't have graft-versus disease. And that makes the process of transplantation, in a way, easier, because by around 3 or 4 months, because you don't need to have drugs to suppress your immune system for a year to ensure that you don't have a rejection of graft-versus disease, by 3 or 4 months, you are probably able to return to work or to school. It does have the challenge that it still requires full-dose chemotherapy in a way that some of the transplants that we do in the adults don't. So there is no doubt that whether you have a haplo or a sibling transplant in the adult population, when we can reduce these minimally conditioning regimens, you get less chemotherapy in a conventional transplant than in gene therapy. But graft-versus disease and the associated complications when you mismatch an immune system are the main reason why people may not survive a transplant. There's no doubt about that. So the transplant process is a lot easier with gene therapy and shorter. However, with gene therapy, you have to be able to collect the stem cells beforehand to be able to edit and manufacture them in the laboratory. And in sickle cell disease, collecting stem cells is quite challenging for a variety of reasons. You can only use some drugs because some of the drugs give you crisis, but actually the bone marrow of patients with sickle cell disease has a very sharp decline once they get into the certain age, into the 20s, in the amount of stem cells they have because of years of lack of oxygen delivery and so on. And so most, only a third of the patients with sickle cell disease can collect enough cells with 1 round on apheresis. A third will require a second collection, and another third will require somewhere between 3 to 6 collections. And, you need to collect the cells, you then need to manufacture them. That takes maybe 3 to 4 months. So it might take you a year and a half before you can go and have your gene therapy. And around 15% of the patients, no matter how many rounds of collections, you can never get enough cells. Yeah. So you gain in an easier, shorter, safe transplant process, but you lose in the having to collect the cells probably several rounds. So when I put all this together, what do I think? I think for thalassemia it's very straightforward. Conventional transplantation does not give you great results, even with brothers and sisters, once you get into adulthood. And you should just go gene therapy. In fact, I know it's only commissioned, it's only allowed if you don't have a sibling donor. If I had my way, I would give it to everybody, even if they have a sibling donor. For sickle cell disease, it's a bit more complex. And I think that is probably still the best way forward. If you are a relatively young person who don't have a serious disease in your organs. So if you are a teenager, particularly late teenager, or if you are in your 20s or very early 30s, I think for that cohort, gene therapy is going to be great. But if you are maybe into the 30s or older, or you have any type of damage to your kidneys or your heart or your lungs that will make the full dose of chemotherapy required for gene therapy a problem, I think, as you have seen, the results of a haplotransplant is really good for that cohort. And I don't think in sickle cell disease, at least for the moment, we will ever say that gene therapy is better than having a transplant from a brother or sister in a way that we might be able to say for thalassemia. So I think there's a role for both. There are lots of patients with sickle cell disease who will benefit from curative therapies, and with the best will in the world, actually there will be no capacity for a single patient to have, for every patient to have the same therapy. I think there will be a role for everything. There will be a role for PK activators, for conventional transplantation, and for gene therapy, and we just need to focus on the right group of patients.